So good morning. I'm Michael Hart. I'm one of the cardiologists with Minneapolis Heart Institute here at Abbott Northwestern Hospital. And for those of you that don't know, I did train here as a cardiology fellow not too long ago, and since have been fortunate enough to return as staff. I'm excited to speak to you today on everything I've learned along the way on the management of cardiogenic shock in a contemporary CCU. Our objectives today are to establish a consensus definition for cardiogenic shock, how it manifests, and how to stage and phenotype it. We'll review the pathophysiology of cardiogenic shock and how it informs our management strategies, with a particular focus on temporary mechanical support options. And then we'll end with a real-world case here at MHI, putting it all together. So epidemiologically, cardiogenic shock is an ever-present problem in our CCUs, with hospitalizations attributed to CS tripling from 2004 to 2018 and still rising today. Though despite our advances in recognition and treatment, it remains a leading cause of morbidity and mortality in the CCU, especially in cases of acute MI complicated by cardiogenic shock, which previously was the predominant underlying etiology of CS in the CCU, affecting our older patients disproportionately. These days, we're seeing a much more heterogeneous group of CS patients with heart failure-driven cardiogenic shock, accounting for almost half of cases in contemporary registries, not to mention other etiologies, including complications from complex valvular pathology and interventions, arrhythmias, and acute inflammatory conditions such as myocarditis and sarcoid. There have been variable, generally trial-driven definitions of cardiogenic shock over the years, though the general tenets have remained about the same. With the recently released 2025 ACC expert consensus document placing major emphasis on speaking the same language, cardiogenic shock is typically characterized, though not solely defined by, hypotension with a systolic blood pressure less than 90, or the need for vasopressors to stay above that threshold, evidence of end organ hypoperfusion, and cardiac dysfunction. Advocating for this suspect CS mnemonic to encourage early identification of this highly morbid condition. Now, beyond the classic cold and wet, warm and dry framework we've historically used in defining these patients, there more recently has been a push to implement both hemodynamic and metabolic variables to identify phenotypes of cardiogenic shock that have been validated to be independently associated with increasing mortality across clinical profiles, with cardiometabolic being the highest risk phenotype associated with right ventricular involvement, characterized hemodynamically by an elevated right atrial to wedge pressure ratio, and a drop in PAPI, or pulmonary artery pulsatility index, which reflects RV contractility, pulsatile load, and congestion. In addition to phenotyping, we know it's critical to stage patients using this pyramid endorsed by SCAI, also previously validated to be predictive of mortality, outlining key identifiers of those patients at risk, those starting to exhibit signs of classic cardiogenic shock, progressing all the way to full-blown extremis. Properly staging and phenotyping these patients often requires the use of a Swan-Ganz catheter, and while randomized data supporting its utility in the CCU is lacking, early and complete hemodynamic profiling has been associated with lower in-hospital mortality in observational studies, and is generally accepted as necessary when managing patients at higher stages of shock to help tailor therapy accordingly. Putting it all together, non-congested CS patients tend to be younger, presenting at lower sky stages with normal end organ function. Cardiorenal patients are typically older, have multiple comorbid conditions, and suffer from LV dominant congestion, while cardiometabolic patients are our sickest, often exhibiting multi-organ failure due to isolated RV or biventricular shock and congestion, with variable mortality depending on what etiology, stage, and phenotype you're dealing with. As illustrated in this retrospective analysis of almost 2,000 patients from the Cardiogenic Shock Working Group and Danish RetroShock MI registries, cardiometabolic CS patients had an over 80% probability of reaching sky stage D or E during hospital stay, independent of shock etiology. Furthermore, acute MI cardiogenic shock patients clinically struggling with LV predominant congestion reaching only sky stage C had a 14% probability of in-hospital death. In stark contrast to the same patient, should they reach sky stage E, escalating to an in-hospital mortality probability of 63%. Therefore, the real utility of characterizing patients in this way is to identify those at highest risk for moving up the pyramid. We know based on additional registry data that the first 24 hours is a unique window of opportunity to impact outcome, where 50% of patients presenting at stage B or C escalate to higher sky stages during that window, and over 90% of stage D patients stay put. Now, beyond that first golden day, few patients move up or down the pyramid, which holds true irrespective of CS etiology. This is an important signal, as we've really yet to consistently identify and implement reliable predictors of worsening shock. Though we do know that treatment of these patients is not a set it and forget it endeavor, but rather a dynamic process that requires frequent reevaluation and restaging by a multidisciplinary team. This, in part, has led to the aforementioned expert consensus statement advocating triage of patients based on level of care needed, utilizing a hub and spoke model similar to our level 1 program to facilitate transfer of these patients to our high volume CS center from afar, which is a framework associated with significantly lower mortality for both directly admitted hub hospital patients and for those that are transferred in, likely due to enhanced access to interventions, including complex PCI or higher risk surgery, as well as non-procedural frameworks in place like multidisciplinary shock teams similar to the one we employ here at MHI, the implementation of which has been associated with reduced in-hospital mortality locally through more timely recognition of cardiogenic shock and escalation of support as appropriate. Okay, so we've identified, phenotyped, and risk stratified. How do we begin to initiate treatment? Well, it really starts with a foundational knowledge of cardiogenic shock pathophysiology, the metrics we follow, and how those dictate our goals of treatment. When we compare pressure volume loops at steady state to those in acute MI and cardiogenic shock, you see a significant reduction in the slope of Emax, or load-independent contractility, as well as an increase in left ventricular end diastolic pressure, resulting in a severe drop in stroke volume seen as a rightward shift of your PV loop and concomitant reduction in stroke work, which drives in part a decrement in MAP and cardiac output, manifesting as increased serum lactate as a surrogate for tissue perfusion and progressive multi-organ failure. For acute MICS, priority is placed on urgent revascularization, as supported by the all-familiar shock trial published in 1999, and its longer-term follow-up data demonstrating mortality benefit at 6 months, 1, and 6 years. Beyond revascularization, to achieve our goals of BP support and enhanced tissue perfusion, we typically initially reach for systemic vasoactive agents, shown here broken down into various subcategories based on their hemodynamic effects, employed to optimize tissue oxygen delivery, though often coming at the cost of increasing cardiomyocyte oxygen consumption. There have been several trials conducted historically supporting the use of inotropes compared to vasopressor use alone in the setting of cardiogenic shock, though none proving benefit of one agent over another. The most recent addition to this aggregate is the Do-Re-Mi trial published in 2021, which was a randomized control trial performed at a single quaternary care CCU across 3 years on patients admitted mostly with SCAI stage CD cardiogenic shock, randomized in a 1-to-1 fashion to dobutamine or milrinone, showing no significant difference in respect to the composite primary outcome, including in-hospital mortality, the individual components of the primary outcome, nor the secondary outcomes across all subgroups, adding important data to the literature despite its single-center nature and debated power calculation. This, in turn, leaves us as practitioners to really rely on mechanism of action, anecdotal experience, and gestalt when making clinical decisions on use. Now, there also has been interesting work published on the prognostic value of cumulative vasopressor burden throughout hospital stay in treatment of cardiogenic shock, showing peak vasopressor requirements within the first golden 24 hours is strongly associated with in-hospital mortality, independent of CS etiology or SCAI stage. Further advocating for the reservation of inopressor support alone as a first-line therapy in those patients with SCAI stage BC shock, while evaluating early and often the necessity of escalating care to include temporary mechanical support. Now, I know what you're thinking, trusting human life with machines, what possibly could go wrong? But in reality, there are several benefits unique to temporary MCS in the management of cardiogenic shock. Hemodynamically, these devices work to achieve an increase in myocardial oxygen supply, or DO2, while reducing myocardial oxygen demand, or VO2, all in an effort to avoid a state of tissue dysoxia, which is the anabolic threshold at which tissue metabolism switches from aerobic to anaerobic, typically at a DO2 to VO2 ratio of 2-to-1, in part achieved by reducing the burden of vasoactive agents needed to support your patient. How exactly does MCS achieve this? Well, to increase oxygen delivery, devices must increase MAP and reduce LVEDP, thereby improving perfusion pressure while decreasing myocardial wall stress-related microvascular resistance. The pressure volume area is our strongest index of myocardial oxygen consumption and includes stroke work, as well as the residual or potential energy stored within the myocardium. Those devices that both reduce the area within the loop and shift the loop to the left favorably affect that DO2 to VO2 ratio. Now, the first major mechanical support device available to us was the intra-aortic balloon pump, acting as an ECG or pressure-gated volume displacement pump to indirectly unload the left ventricle, providing minimal forward flow, though robust diastolic pressure augmentation. Hemodynamically, amongst available mechanical support options, it alone offers a favorable reduction in both steady state and pulsatile afterload, acting to reduce myocardial wall stress and ischemia while increasing stroke volume and coronary perfusion pressure. Despite this, the SHOCK 2 trial, which we're all familiar with, failed to show its use in acute MICS reduced rates of early or late mortality irrespective of its employment pre or post PCI, nor was there a difference in infarct size or secondary clinical outcomes, including death, albeit in a non-SHOCK cohort in the subsequent CRISP AMI trial. This has since led to a downgrade in level of recommendation to Class 3 for routine use of IABP in acute MI complicated by cardiogenic shock, which is now in lockstep with European guidelines. More recent data has pivoted to analyzing IABP use in heart failure cardiogenic shock, these including the Italian National Multicenter RCT ALT-SHOCK 2 trial, published just earlier this year, also failing to show mortality benefit or successful bridge to advanced heart failure therapies, halting enrollment at its enrollment interim analysis for futility. With all this being said, there have been efforts to identify those specific patients for whom physiologically balloon pump would provide the most benefit. These responders are characterized by LV predominant shock with postcapillary pulmonary hypertension and an elevated SVR state. In some, a SCAI stage BC patient with cardiorenal phenotype. Now, in our CCU, its utility primarily lies in providing coronary perfusion support in patients admitted with acute MI, say with distal left main disease as a bridge to CV surgery, or as a left ventricular unloading modality in the setting of VA ECMO. For SCAI stage D patients who require a higher level of mechanical support, our next option is Impella, which mirrors the action of the ancient Greek Archimedes screw, pumping blood from the LV to the aorta at various max flow rates, depending on device size or power level in use. And while admittedly likely an oversimplification, we can go back to our PV loops, which, in contrast to VA ECMO, show a reduction in LV pressure and volume with Impella use through LV aortic decoupling, effectively decreasing stroke work while increasing cardiac power output, which is our strongest hemodynamic predictor of in-hospital mortality. Through LV unloading and CPO augmentation, we also see improvement in coronary perfusion pressure, which speaks to Impella's utility in high-risk PCI supports, the data for which includes the PROTECT 2 and 3 trials. Naturally, these results were followed by studies done on Impella use in the cardiogenic shock space, these including IMPRESS in 2017, showing no difference in patient outcomes between Impella CP and IABP-supported patients with acute MI cardiogenic shock, though notably with 90% of trial participants suffering cardiac arrest with an average lactate level exceeding 8 and anoxic brain injury serving as a major cause of death, thus raising the question that maybe these patients were just too sick, essentially SCAI stage E, to benefit from Impella alone. More recently, we have the landmark DanGer shock trial published just last year. which was an international multi-center RCT conducted in Denmark, Germany, and the UK on the utility of microaxial flow pump, i.e. Impella CP, in managing STEMI complicated by cardiogenic shock compared to standard of care alone. With, importantly, very strategic patient selection, most notably the exclusion of comatose cardiac arrest patients with a GCS of less than 8 and those with biventricular failure. These patients were predominantly male with traditional cardiovascular risk factors, and the majority adjudicated as SCAI stage C. Amongst those in the Impella arm, 85% were placed on support pre-PCI. The primary endpoint, all-cause mortality at 180 days, occurred in 46% and 58% in the Impella versus standard of care group, with a hazard ratio of 0.74 and a number needed to treat of 8. The difference in composite secondary endpoint was also significant and in favor of Impella, consisting of escalation in MCS support, heart transplant, or death from any cause. Adverse events were, as expected, more common in the Impella group, with a number needed to harm of just 6. There was a 2-fold higher risk of moderate or severe bleeding, a 5-fold higher risk of limb ischemia, as well as a significant increase in acute kidney failure requiring temporary renal replacement therapy, which many have posited to be a result of the study protocol mandate to flow Impella as high as possible for the first 48 hours before weaning could be considered, understanding that aggressive unloading with higher Impella performance levels may come at the expense of increased risk for hemolysis and subsequent pigment nephropathy, which we know historically has been associated with poor long-term outcomes in the acute MI and CS populations. Now, despite this risk, the mortality benefit of Impella in this study held true independent of the occurrence of AKI or need for dialysis. And among survivors at the 6-month mark, no patients required long-term renal replacement therapy. This emphasizing the importance of striking a balance between flowing enough to unload while limiting support to avoid complications. So just a single trial that took 10 years to enroll, it stands alone as the first and only RCT in this field to yield a positive primary endpoint, leading to a Class 2A recommendation for Impella use in the treatment of ACS complicated by cardiogenic shock. But how do we apply these results in our day-to-day real-world practice? Well, in this multi-center registry analysis published by the Critical Care Cardiology Trials Network, amongst over 20,000 CICU admissions between 2019 and 2023, only 245 patients were danger shock eligible, re-emphasizing the importance of carefully classifying patients based on all available clinical data in order to identify those cases where the risk-benefit ratio is favorable. Now, what about those patients in the upper echelon of our cardiogenic shock pyramid? The stage DE cardiometabolic phenotypes with in-hospital mortality rates reaching upwards of 60%. In these patients requiring full cardiorespiratory support, VA ECMO is our last line of defense. With its inception dating back to the 1940s and 50s, where there was a race to develop the first sustainable heart-lung machine, ultimately culminating in the contemporary ECMO circuit we're familiar with today. And while its use was initially reserved for the pediatric, then adult ARDS populations, Owing to several observational trials demonstrating improved neurologically favorable survival with ECLS compared to standard care alone, coupled with the approval of HeartMate 2 for bridge to transplant in 2008, we've seen an over 1,200% increase in ECMO runs in the last decade. In contrast to balloon pump and Impella, VA ECMO uniquely provides full biventricular circulatory and oxygen support, lending to its utility in a number of different clinical scenarios, including acute MI and heart failure-related cardiogenic shock. Also, in turn, allowing for implementation in different clinical settings, from the ED to the cath lab and famously even the Louvre. Until recently, data for or against routine ECMO use in cardiogenic shock has been observational, though we now have 2 randomized trials performed in the last 3 years analyzing just that, the first being ECMO CS, which randomized 122 patients with stage DE shock to early ECMO use or conservative therapy, showing no difference in rates of the composite primary outcome nor death from any cause, though notably with significant crossover from the conservative treatment to VA ECMO group at 39%. This was followed shortly thereafter by the ECLS shock trial, focusing specifically on the acute MI cardiogenic shock population, randomizing about 400 patients admitted with cardiogenic shock to ECMO versus usual care. These patients had a median lactate of almost 7, though a lower proportion were deemed in refractory shock, with about 50% adjudicated as stage C. ECMO was initiated pre-PCI in about a quarter of patients, peri-PCI in another quarter, and post-PCI in the remaining half. Almost all patients underwent distal perfusion cannula placement, though notably only 6% had some form of mechanical unloading. The primary outcome of 30-day mortality occurred in 48 and 49% in the ECLS and usual care groups, with no difference seen at the 1-year follow-up report. These results held true in the subgroup analysis as well, including pre-ECLS cardiac arrest status. There was, again, as expected, significantly more bleeding and vascular complications in the temporary mechanical support group. And important caveats to keep in mind, including the use of a lactate-driven post-hoc adjudication system for designating SCI stages, the overwhelming number of resuscitated cardiac arrest patients, confounding the impact of any form of MCS in a population at such high risk for anoxic brain injury, not to mention the low rate of LV unloading while on ECMO support, and the lack of data on what proportion of these patients were transitioned to advanced heart failure therapies. The final point proving particularly salient for a technology that serves as a bridge, not just to recovery, but durable MCS or transplant as well. So, in summary, what is the role of temporary mechanical support in managing cardiogenic shock? Well, for acute MI, the most recent guidelines are clear that routine use of balloon pump or VA ECMO is not recommended, with Impella carrying a Class 2A designation a la the Danger Shock trial, with particular emphasis placed on patient selection. In heart failure cardiogenic shock, given the absence of large randomized controlled data, recommendations for temporary MCS implementation are driven by the phenotyping and staging we reviewed earlier and outcomes from observational data. Now, with a weekend of night call on the horizon, it would be bad juju if I didn't pause to say something about the right ventricle and the havoc RV failure can wreak. RV predominant cardiogenic shock is an entity that has even less robust data directing its management, though can manifest as a complication of acute MI, pulmonary embolus, and not uncommonly in the post-cardiotomy population. As we know, the most common cause of RV failure is LV failure. So often treatment starts with optimization of left ventricular hemodynamic conditions, though also include strategies to mitigate issues unique to right ventricular failure, specifically RV-PA uncoupling, which speaks to the interaction of RV contractility with changes in effective arterial elastance as a measure of afterload. These strategies include the use of inhaled pulmonary vasodilators, the selection of which was evaluated in the Inspire Flow trial, a single center RCT showing no difference in postoperative RV failure, nor mortality between inhaled epoprostenol and nitric oxide. MCS options specifically designed to provide univentricular right-sided support include the Impella RP, and Protec Duo devices, the latter providing a conduit for oxygenation support if necessary, and used most often in our institution for post-VAD RV recovery. All right, with our remaining time, let's review a recent case in our cardiac ICU that puts all of this together. We have a 73-year-old female with traditional risk factors, though no previous cardiac history, who presented with 3 days of stuttering, chest burning, reminiscent of previous GERD, though ultimately prompting presentation to her local ED for evaluation. There she was vitally stable with unremarkable physical exam, a troponin level of 4.3, an ECG deemed ischemic, though without definitive current of injury, and a limited POCUS quoting reduced EF. She was subsequently diagnosed with NSTEMI, initiated on appropriate medical therapy with arrangements made to transfer to our facility for further evaluation and management. Now, at this point, I think we can all agree this patient is SCI stage A, or at risk due to her relative clinical stability, though somewhat delayed presentation, borderline lactate level, and reported LV dysfunction. Unfortunately, shortly after loading her into the ambulance rig, she suffered pulseless VT arrest, which soon degenerated to VF. Resuscitation efforts immediately ensued, including CPR, several shocks, and endotracheal intubation. She was actually wheeled back into the outside hospital ED, where ROSC was ultimately achieved, and repeat ECG showed findings similar to her pre-arrest study. She was able to follow simple commands, giving her a GCS of 10, though by this time was requiring low-dose Levophed for blood pressure support, with repeat labs showing a pH of 7.25 and a rising lactate to 4.1, taking her from SCI stage A all the way to SCI stage D, with an in-hospital mortality risk predicted at 56%. As a result, appropriately so, our MHI shock team was activated and she was brought immediately to the cath lab for further evaluation. There, Swan-Ganz catheter was placed, showing elevated left-sided filling pressures and reduced cardiac index consistent with an LV-dominant cardiorenal phenotype. Dobutamine was started, Levophed titrated, and coronary angiography obtained, showing a culprit LAD lesion, which was subsequently ballooned and stented. In line with danger shock, Impella CP was subsequently placed in the hopes this would be sufficient support. Though unfortunately, over the next 30 to 45 minutes, her pressure requirements did not improve, but rather started to climb. During this time, her right atrial pressure was also rising, with an attendant drop in PAPI, indicative of impending RV failure as well. This, coupled with her marginal oxygenation, prompted further escalation to VA ECMO cannulation and inhaled epoprostenol support. Over the next several hours, she continued to need exceedingly high pressure doses, with serial hemodynamics supporting a prominent post-arrest vasodilatory component to her shock, consistent with progression to SCAI stage E cardiometabolic phenotype. No doubt in part due to a large aspiration event surrounding her inciting arrest, coupled with initial formal echocardiogram showing severe biventricular systolic dysfunction with an LVF in the 10% range. Fortunately, utilizing both chemical and mechanical support, we were able to weather the first 24-hour storm. By day 2, her support needs had improved considerably, allowing her to liberate from both ECMO and Impella with the aid of our vascular surgery team. She was extubated the following day, completely neurointact, with an updated echocardiogram showing near normalization of her LV function, corroborated by subsequent cardiac MR. She discharged hospital day 9 to a rehab facility and ultimately went home 1 week later. Now, this case, while anecdotal, does demonstrate the necessity of serial evaluations and shifts in treatment strategy that the management of cardiogenic shock demands. It's also representative of the broader success our shock team here at MHI has had in treating these very complex patients. Over the last 4 years, we've seen a consistent decline in balloon pump use in line with the aforementioned ACC guidelines, corresponding with a significant climb in Impella and VA ECMO volumes. And despite employing these temporary mechanical support devices in an ever-increasing number of complex patients, our survival rates have remained consistent and compare very favorably to national reports, with Impella survival to explant in our acute MI and heart failure cardiogenic shock patients exceeding 70%, and rates of survival to ECMO decannulation well exceeding the national average according to recent ELSO registry data. In conclusion, we've reviewed the definition of cardiogenic shock, its various etiologies, and the criticality of phenotyping and staging, particularly in that first golden 24 hours. We discussed its pathophysiology and how that directs what tools in our arsenal we employ, and ended with a case applying these tenets here at MHI. Thank you for your time. Any questions I can answer?
Thanks, Mike, for that great talk. So I think that woman highlights the importance of stun myocardium. And just the fact that you got to just jump on these patients and they quickly change course like her LV function did. I think if that was another patient, some of these late presenters where their artery's been occluded for like 12 hours and they have no viability left, the outcome would have been quite different. Just another side question. When you look at balloon pump and all the pathophysiology, all the potential benefits, it's a little surprising that it doesn't help at all. Why do you think that is?
Yeah, I think, from a coronary perfusion perspective, when, the artery is not occluded and there isn't, ongoing torrential ischemia, it can be helpful in stabilizing a patient as bridge to CV surgery. But, I think, once the cat is out of the bag, in the context of like true acute MI, flush occlusion, the downstream kind of microvasculature is already, uncoupled from the LVEDP, and that's not something that, I think balloon pump is going to reverse both in that aspect, nor in a way that's going to provide adequate MAP and cardiac output support. And at least the cohort of folks that are manifesting true acute MI cardiogenic shock as a result. So while it's seemingly less invasive than Impella and comes with again benefits in that specific population, for whatever reason outside of that small group of responders that I highlighted, these folks that are slipping beyond LV dominant congestion, cardiorenal phenotype into more cardiometabolic just need a higher level of support.
So my question specifically regarding Impella is about the timing. And when do you consider Impella for patients who are, for example, stage B, C before they deteriorate into higher stages?
Yeah, it's a great question. I think historically we've gotten into trouble just applying temporary MCS or any sort of cardiogenic shock therapy to the masses, and not surprisingly, we haven't seen benefit on the back end. So I think the Danger Shock trial was really well done, although it took 10 years to enroll. It was a very, very specific cohort of patients. Now, could you say, based on the results of the upcoming, unload trial with Impella in the context of acute MI or cardiogenic shock and timing related to PCI, is there another, small cohort that would benefit from, maybe 24 hours of mechanical support as opposed to, lower levels of, chemical LVAD, inotrope supports in the ICU? That's certainly possible, but I think it just kind of remains to be seen. Certainly, when you look at the downside of MCS, exceedingly higher rates of major bleeding or at least moderate bleeding, limb ischemia, et cetera. So it's just trying to strike that balance, who you think really needs it, and who that risk-benefit ratio is going to err on the latter.
Well, thank you, Mike. And I agree, and I'm part of all this, and I think this is the right way to go. But I always have this debate. Debate regards the data doesn't really back up ECMO, and actually that was the reason why we took the balloon pump out of our normal strategy. So we took one out, but we believe in the other one, which we do, even though the data doesn't really support it.
Yeah.
And we all believe, because at one point we cannot just keep going up on drips, and that's what we think mechanical support. Yeah. But again, there's a debate of how much we actually do, and actually we're supported with information with it.
Yeah. Yeah, I think it's such a difficult group of patients to study because they're just so sick. So performing, a large multi-center randomized trial, looking at whether or not ECMO helps in those patients is very difficult. I would say, the class of patients from a sky stage and phenotype perspective that, physiologically we think would get away with balloon pump support is very different than I think, the cases in which we feel like ECMO is our kind of last line of defense, because it is so invasive and comes with a lot of risk. I agree with you, though, the ECMO data is really not any better than the balloon pump data. I think just by merit of what it provides in essentially keeping the patient alive and providing, IV support, oxygenation support, there's just enough added benefit to argue that, we're pretty much in extremis at this point, and so it's either this or nothing. So, obviously moving forward, we hope with collaboration with other centers and, as a result of these registries that are put together, we're able to kind of tease out what patients do benefit in the end from employing, again, such an invasive MCS modality. As it stands, it's really, kind of when things are crashing and burning, our best option.
So just being in the cath lab and, often having to deliver some of this therapy, it seems like we're reflexively asked to add Impella every time we put someone on ECMO. And just I think there was just a paper that was just published, because the thought is it makes sense. You think of ECMO, it increases your afterload, so it's going to increase your EDP and your wall stress. But I think it was like last week a paper came out that actually did invasive hemodynamics with ECMO, and actually found in the majority of patients that when you got put on ECMO, your wedge actually went down, and not what you think is up. So maybe we also need to rethink the whole, automatically put someone in Impella, just because they're on ECMO.
Yeah,
It's very expensive therapy
100%.
to do, and
Yes, yeah, I think it needs to be hemodynamically driven, and there's really no scenario in which someone should be on ECMO without a PA catheter in place. And I'll also, akin to what we did in this case, it's okay to put someone on support and wait in the cath lab, even though it feels like, let's get in, get out, get the hell out of here, get them up to the ICU. I think there's a lot of added benefit, particularly given the dynamic nature of these patients post-arrest. You're just kind of waiting for the next shoe to drop in the way of, kind of the cytokine storm they seem to exhibit. And so watching hemodynamics as you spend, 30 minutes on flow to say, well, what is my pulse pressure? What is my wedge or EDP? Is this someone that would truly benefit from Impella, or am I just doing this to do it? Because, again, the data related to complications would argue, you should have a good reason to do so. I think just colloquially speaking, nationwide, there's a lot of support for unloading with Impella in the setting of ECMO, or unloading, as a strategy in general in those folks that need it. But I agree. I think the reflexive, let's add in Impella anyway, physiologically probably doesn't make a ton of sense. But oftentimes we find that it's necessary based on the hemodynamic data.
Was there anything on that case that you presented that, looking back on the triage, should have been considered level 1? Or for us that are C5, is there any other things we should be looking at on those quote-unquote NSTEMIs level 2 that we should be maybe looking at doing more urgent transfers? So if they arrest, they're like either close to us, or we get them before they arrest?
Yeah, it's so hard, I think, trying to parse out what patients are, very stable NSTEMI and wouldn't benefit from, immediate revascularization, especially if they're not having pain, et cetera. I think in retrospect, there were just a couple warning flags, again, a lactate that is near the upper reference, limits of normal, the LV, decrements on POCUS, the somewhat delayed presentation. As you're on the phone with these providers and you're trying your best to gain some insight as to how they look. Sometimes it's a gut feeling. I will say, I try to get into the habit when I'm on the other end of those calls and asking for a lactate, even in the folks that are coming in with STEMI, and we know they're going to the cath lab because, one, it takes like an hour for it to come back, so it's nice that it's cooking when they're en route. But two, I think it's helpful for temporal testing. We'll get one as soon as they get here, and that'll help direct whether or not they would truly benefit from MCS. But just understanding, as we all do, but it's a good reminder, these patients can turn. This is a highly morbid condition, and it again speaks a little bit to us doing our job and reaching out to referral centers to say, we're here, we're available, we want to know about these patients. Even those that aren't in, acute MI, cardiogenic shock, those that are admitted, with decompensated heart failure to these local centers, having a frank conversation about what does cardiogenic shock look like, and trying to educate them so that we're able to identify those patients that would benefit from being under our roof, where we do have the frameworks in place to adequately care for them. Great, thanks everybody.